Today I want to talk about actually a very serious subject that we're starting to see some of the information really begin to surface. And I want to delve in a little bit around the concept of whether or not can digital health actually bring health equality, or can we improve health equality by encouraging digital technologies, digital health. And specifically, I want to look at how the cloud in general is leveling access to healthcare, and then delve into a little bit of detail about some of the things around that AWS is doing in the cloud. So let's talk a little bit about agenda today. Just want to talk about the current state of healthcare equality that we see, not just in the United States, but internationally. And I want to also talk a little bit about a sample of how that equality was impacted during the pandemic. Then we want to move on to some of the recent advances that specifically target some of these health inequalities that we're seeing, and then how AWS is advancing the need and the ability to deliver results in repair of those things. So first of all, let's take a look at the state of healthcare equality. Now, before we take a look at the state, we have to understand exactly, let's put our words around, let's make a definition of what we're talking about. Now, the U.S. Department of Health and Human Services basically says, health equality is the state in which everyone has a fair and just opportunity to attain their highest level of health. This means that the focus is typically on addressing historical, contemporary injustices, how economics, social, other obstacles play in, such as cultural or political, and then being able to eliminate preventable health disparities, things that are obvious or that are easily to repair, mitigate, are the things that are being addressed first. So that's how Health and Human Services takes a look at it. And it gives us a very good understanding of what we're referring to when we talk about health equality. Let's talk about some of the stats. I think when we deal with the numbers, it makes it a little bit more real. One of the things that recently was discovered is that Black, African Americans, Hispanic, Latino, and American Indian and Native Alaskan populations in the U.S. actually experienced higher rates of hospitalization and death from the COVID-19, even when people were accounted for around their demographics or their socioeconomic factors like age or income. These groups significantly always in these recordings of these statistics rated higher in their hospitalization and death. That is a disparity. There's something there, and we need to explore those things. The other thing is, during the first year of the pandemic alone, we saw about 119 to 124 million more people enter into not just poverty, but extreme poverty during that first year. Those are the types of disparities of health that we're taking a look at. Here's some other things, and these are universal across the globe. The under 5 mortality rates in the poorest households are double that of the richest households. Life expectancy in low-income countries is about 16 years lower than high-income countries. Rural issues often play a very, very heavy part in health inequalities. For example, that 80% of the world's population live in extreme poverty. Well, the previous stats show that if you're living in extreme poverty, that you are expected to have a lower life expectancy than those that don't live in these extreme poverty. We also see that 8 out of 10 people internationally lack basic drinking water. That's a very, very high number. 7 out of 10 people lack basic sanitation. This is a very, very significant thing that's going on around the globe. This is not a small impact. So let's take a look at this in light of the pandemic. What did we see in the pandemic? What happened? Well, let me give you a little story of how the pandemic typically played out. On December 27th, there was a hospital in Wuhan, China, notified the local Center of Disease Control and Prevention and the health commissions of multiple unknown pneumonia cases that were presenting in the hospital. On the 3rd of January, Zhang Yushan, who is a virologist at the Shanghai Public Health Center, receives these specimens from a 41-year-old Hunan market merchant and animal samples from Wuhan. He labels these human samples as Wuhan Hu 1, and Dr. Zhang begins deciphering the RNA sequencing. On January 5th of 2020, Dr. Zhang identifies the nucleotide sequences of a SARS-like virus. He finishes sequences it by 7 o'clock and then uploads the genomic sequence to the United States National Center for Biotechnology Information. Then Dr. Zhang notifies the Ministry of Health of contagious respiratory disease and advises protective measures against this particular variant. On January 11th, Edward Charles Holmes, now he's a British biologist, requests Dr. Young's permission to release the genome of the Wuhan Hu 1 specimen. And Dr. Zhang approves, and he says that's okay. And Dr. Holmes then publishes the genome on virological.org. Dr. Zhang, in the process, was not aware that the Chinese National Health Commission had prohibited publishing information, and so it went forward without their knowledge. However, by January 20th, the Chinese government confirmed that the virus could be spread from person to person. So that's the sequence of events in a very short period of time. I did a sampling back in October just to kind of see what's happened over those 2 years since that. And on October 11th, there was 621,366,240 confirmed cases. And more than 6 million, over 6.5 million confirmed deaths at that point. By the 26th, which is basically 15 days later, you can see the stats jump up. And there were new deaths resulting in more than 13,000 people dying and more than 620,000 new cases just in that time period. So the pandemic is still very much active, and that the COVID virus and its variants are still very much out there. So much so that in 2021, the World Health Organization put forth on their World Health Day 5 calls to action that really needed to be addressed, that they felt needed to be addressed. And the number one thing was accelerate equitable access to COVID-19 technologies between and within countries. World Health Organization recognized that this pandemic was exacerbating the problems that we were seeing already around health inequalities. And so there was a call to order, and since then there's been multiple calls to answer the problems resulting in health inequality. So what did we learn during all this pandemic? Now, you hate to say that we learned anything good, but we did learn some things. There was nothing, ultimately good about anybody getting a virus or it being spread across the world, but there were certain things that we did learn that help us advance healthcare in general and help us to focus on health inequalities that exist in the world today. And out of those things that we could, I guess, classify as good or better than expected was there is now a massive acceleration of digital health. Digital health in itself is now considered a fundamental offering by most healthcare specialists around the world, in particular in first world nations and also the United States. There is now an acceptance of an at-home diagnosis. This was not really something that was occurring before the pandemic. There were often skeptics around being able to diagnose correctly at home. There were often difficulties in understanding the differences, the disparities between what was recorded at home and what was recorded in clinical situations. And we also seen a consumerization of digital healthcare and increased competition, a dramatic increase in competition of people trying to not just go to the market, but actually make a difference and try to curb the tide of the pandemic as it spread. The Department of Health and Human Services also lifted several telehealth restrictions and made telehealth more available in certain areas and allowed for reimbursements and allowed for the use of it in treatment more than what was happening before. We also see that that there was a very positive impact on elective surgeries. Prior to the pandemic, there was a lot of elective surgeries that were occurring in hospital situations, and we saw that begin to shift and is now shifted to ambulatory surgery centers, taking the weight off of the hospitals. There's a lot of reevaluation of what's necessary and unnecessary procedures. A lot of people second thinking about whether they should or should not go through some of the elective surgeries. And so that was a positive thing that allowed the world to kind of take a step back around elective surgeries. And the Office of Inspector General also identified the supply chain. If you remember, during this time, the supply chain in hospital systems were dramatically impacted. There were lots of single points of failure. There was not equipment that was available, and that there was very bad organization of supplies and stock supplies. So the pandemic has caused a lot of hospital systems to reevaluate that supply chain, so there aren't those single points of failure, and allowed for many healthcare providers to reach across certain boundaries and certain lines and be able to get the equipment that they need, even the staffing, the supplies and things that they needed. And so that was something that was a growing problem that is now being addressed very heavily because of the pandemic. But like we said, the pandemic was bad. It was really, really bad. And we know that some very serious things rose to the top very quickly in the world of healthcare regarding the pandemic. Probably one of the first things that I want to address is that the pandemic just brought out how serious the problem is of mental health. Close to 1 billion people worldwide live with some type of mental health disorder. That's a lot of people. More than 75% of the people with mental or neurological or substance use disorders actually receive no treatment worldwide. That means that only about 25% of the people worldwide who need to receive some type of treatment are getting some type of treatment. And only 1/3 of the world's population, that's about 2 billion people, that's a lot of people, okay, live in countries that spend less than 1% of their healthcare budget on mental health. Okay, not a lot of money going toward mental health. And the pandemic made this way, way evident and way worse. We saw mental health crisis and substance abuse just skyrocket. It went through the roof. We also saw situations with existing patients missing the preventative care appointments because of the pandemic. They were either maybe afraid to go, or they didn't have transportation, didn't have the ability. But the point is that they missed the appointments that they needed to keep them mentally healthy. Many people who actually were experiencing undiagnosed conditions became more severe because of the pandemic. They locked off, they shut off from society, they shut off from medical treatment, and their conditions grew worse and worse. And it basically come down to because traditional methods of treatment became very hard to obtain. Traditional methods were often shuttled for emergency care situations. Some of the physicians that were practicing were not able to practice as often, or in more social situations where there were groups of people. And it greatly impacted the problems that we see and that we experience with mental health. We also saw the prevalence of anxiety and depression increase by 25% globally, okay? Globally, 25%. Anxiety and depression are very severe conditions, okay? And the prevalence, or people who may have not been exhibiting anxiety or depression, increased by 25% in just 2020 alone. 90% of countries plan increase in mental health and psychological support because of COVID, but they're having to respond after the fact. Services for mental and neurological and substance use conditions were the most disrupted among all of the essential health services. A lot of people who needed treatment did not get treatment, and the pandemic just really exposed that to the world. Another area, if you remember, whenever the pandemic first started, that was very much impacted was nursing homes and assisted living facilities. We saw the COVID virus really begin to take hold in these types of facilities. We saw that it spread dramatically through those areas. More than 1/3 of the COVID fatalities were in nursing homes and long-term care facilities. Traditional close care and consolidated services just created different types of environments that just spread the virus. The virus is communicated between people, okay? And when you have people that are in close contact with each other, the virus spread very, very quickly. By May of 2020, half, okay? May of 2020. Remember, we really didn't address a whole lot until we looked at, Dr. Young was not doing his work until January. So in May of 2020, half of all those deaths in France and Ireland were from nursing homes, okay? During the early stages, 80% of US deaths were in people of age 65 or older. And 50%, now this is a shocking thing, 50% or more of nurses who would normally be treating people in these particular situations in these facilities left their job within a year for a whole host of reasons that were associated with the pandemic in most cases. Workers who had multiple jobs, because now nurses were leaving, now we had nurses that were having to carry a multiple weight and go maybe from facility to facility, created significantly higher COVID rates. A particular clinician could catch COVID in one facility, be able to transmit it in another facility and not even really begin showing symptoms yet. And they were just pushing along, trying to help people as we were trying to learn about this disease. There's an interesting comment that comes from Rotterdam, Erasmus University in Rotterdam. It's from the Department of Psychology, Education, and Child Studies, and it says this: the elderly population, which has been the worst affected by both the virus and the lockdown measures, have seen the least benefits from these digital solutions, talking about digital and technology. The age-based digital divide describes a long-standing inequality in the access to and the skills to make use of new technology. And what they're saying is, not only did we have problems with people not being able to get the medical attention that they needed, in particular digital types of technologies like telehealth or remote monitoring situations, the people that were able to get it didn't have the skills able to use it or learn it or use it effectively. This was an inequality that a lot of people didn't really realize, is saying, okay, if I was able to give someone a particular digital technology or the ability to maybe have a telemedicine style visit, that would reduce those mortality rates. And what we actually found was we were basically dumping technology on people that did not know how to use it or make use of it. And so that was something that really rose to the top, that a lot of people began to look at and have been addressing ever since, is although we produce these technologies, do we know how to use them? Another area that we really didn't quite grasp is in the area of genomics. We really found out we didn't know as much as we thought we knew, okay? Probably one of the most evident things that came out of it is access was very limited to genomic research and some genomic data. Only certain collect groups or individuals were able to get their hands on some of the early things around genomics testing and some of the things associated with it. We found out that there is a massive socioeconomic inequality. And the main reason is that clinical trials are typically only conducted by institutions in high-income countries, okay? Low and middle-income countries are often unable to meet the high demands for molecular testing, the ability to survey the variants, and the vaccine distributions are very ineffective because of these particular inequalities. It affects not only patients, but it affects the entire supply chain. It affects all the researchers. It affects everything associated with it. And most genomics testing was limited to first world or high income countries. Let me give you an example of how that impacts. And this is one that's often overlooked. A lot of people don't know about this particular one. But this is an example of a double impact that the pandemic really nailed us with. there is a condition, oxidative for phosphorylation, okay, that prevents the cell's mitochondria from extracting energy from food. It is a mitochondrial disease. So basically, a cell takes a certain amount of energy and extracts from food or other sources when it goes into your body. And this mitochondrial disease prevents the body from being able to extract all the energy that it needs from these particular sources. When children experience mitochondrial disease and they get sick with any type of virus, not just the COVID virus, any type of virus, they struggle to produce enough energy to fight that infection. And of course, any infection that goes on, it continues to weaken the body. And eventually, a viral infection with a child that has mitochondrial disease, it can become very much life-threatening. The COVID-19 created a significant threat to the community because, first of all, children who have the disease are battling a virus. They're not getting enough energy from food and from any other sources that are coming into them. And it often creates an experience where their organs begin to dysfunction and fail on them and cause the disease to progress, even to points where we see movement disorders, we see seizures, and just a continuing ongoing injury to the complete nervous system. So that the virus hitting that in these children is the first impact that you see, and they're having to battle that. Well, remember we talked about the situation with nurses leaving the nursing home and the assisted facilities. Well, a lot of those clinicians cover multiple children with this mitochondrial disease. And that also allowed for the spread of COVID in many situations. A physician would be in one place and they would go to multiple locations and increase the risk. So this is a case where the COVID actually has a double impact because clinicians now are in limited supply. They're having to spread across multiple clients. And these conditions are affecting children with their inability and causing the virus causing their body to continue to break down at an accelerated rate. So that's kind of a double thing that we saw in the genomic sequence or the genomics arena. But there have been some recent advances. There have been some really good things that are targeting health equality that we've learned based on the pandemic itself. And so I want to talk a little bit about some of those advances that we have saw that are targeting health equality. So current cloud deployments, we're seeing more and more providers, vendors, clinicians, everybody just moving to the cloud. We are seeing new digital experiences. The cloud is opening up the opportunities for new people. It is allowing for flexible work. It is really strengthening the business community. It has incredibly increased the amount of competitiveness across the market. And we all know that whenever vendors compete, we tend to get a better product, and everybody's trying to create their product better and better. So there is an intensified effort in healthcare that is moving a lot of things to the cloud. And so we are seeing those benefits of cloud technologies and cloud compute. We are also seeing that the pandemic has increased an incredible amount of cloud spending. We see that most organizations are focusing on the things that grow beyond just what they're able to do in their own data center, and particularly increased security. You hear every day about new AI-based, and we're seeing self-service things coming out of that. You see a lot around machine learning. We're seeing old IT infrastructure now being upgraded into new and modern equipment that's faster, that allows for scalability and expansion. And we're seeing in the next 12 to 18 months, a lot of IT priorities around the adoption of 5G. We talked about AI ML-based services. There is a lot of stuff going on in the AI ML space, a lot of encouraging things. I think one of the things to be aware of is oftentimes we're always thinking of AI and ML being these very new progressive technologies, these new bleeding edge things. AI and ML are also cleaning up a lot of things that were not done necessarily effectively in the past. They're creating new opportunities. They're saving clinicians a lot of time in the experience they are. They're finding new areas that were overlooked. And cloud providers are coming up with new and innovative ways and easier ways for people to work in the AI and ML environment. And of course, we're always worried about security, but we're seeing an incredible amount of posturing and spending around disaster recovery and backup and business continuity. So these are really, really good things that we're seeing in the cloud space moving forward. But we're also seeing health equality and advances, and we're seeing a lot of health equity focus coming through. And AWS, Amazon's Web Services, which is the cloud provider, the very large cloud provider that we're probably all very aware of, has put in a massive amount of focus around health equity. And there's a lot of organizations joining AWS in their efforts to try to break down some of these issues and these silos that have existed in the past. So let's go back to the things that we saw during the pandemic and see how people are trying to address some of the problems that we saw that were experienced during that time. So one of the first things we talked about was mental health, right? We talked about how bad that is. We see still today that approximately 1 in 5 Americans has a mental health condition, okay? That means that everybody that's listening to this knows someone that has some type of mental health condition. When you have those 1 in 5 numbers, it's just so high. You know somebody, you may not know that they have a condition. It may not necessarily be super impactful, or it may be very bad, but basically everybody knows someone who has some type of mental health condition. But out of those 1 in 5, over half of those people don't receive any treatment whatsoever. And when we look at why are they not receiving treatment, why are they not getting the treatment that they need, there are multiple factors that continue to crop up, and factors that we have the ability to address. And I think that's part of the key with a lot of health equity that we found out is the things that are impacting people, very often we can do something about. Okay, that's really the key. If you take away anything today, I want you to take away the fact that a lot of the problems that the world is experiencing, we have the ability to do something about it. So people come up to me and they say, what should I do? I used to give them all these examples of you do this or you do that. Now I just tell people, do something, okay? Don't do nothing, okay? That's a double negative, I guess, but you do something. What should you do? Do something. There are so many organizations, there's so many ways that you can address this. And just even being supportive of people around you is a fantastic way of doing something. So everybody should do something. Now, going back to the mental health condition, why are people not necessarily receiving mental health? Well, there's multiple factors. One, there's lengthy wait times. There's not a lot of clinicians available, especially in rural areas, that are able to treat that. Sometimes the treatments are costly. They're very expensive. Transportation is an issue. You know, in the United States, we often don't think of transportation necessarily being an issue, but it is. And when we go to other nations outside of the United States, transportation becomes even greater. There are a lot of people that live in very rural areas that still walk or have to travel by foot to even get to a basic medical treatment, let alone a behavioral health type center. There's a social stigma associated with mental health, and that's not good. You know, over the last 50 years, there's been a lot of advancement in trying to reduce the social stigma and understanding of how many people battle these particular conditions, but we still have a long ways to go. And that prevents people from getting the treatment that they need. And then, of course, there's a lack of health insurance. A lot of insurers only cover very limited amounts of behavioral health. Often the conditions come with many comorbidities, and that causes difficulty. It also reduces the ability of dollars to be placed in the areas that are critical. And oftentimes, especially in behavioral health situations, the comorbidities also have to be treated. So it creates this ladder effect that makes it very difficult. Well, there are some people out there in the world that are trying to address this. One of the companies that are trying to address this is a company called Talkspace. Talkspace is trying to attack the mental health issue in the cloud by providing digital therapy. And their focus is affordable access to professional therapists using web and mobile applications. If I can get a mobile application, a cell phone or a laptop or a device in front of you, so you can see someone in behavioral health specialists or professional therapists. We can address a lot of those follow-up situations in some of those early assessments. So Talkspace is one of the companies that is coming to the forefront and addressing this. And the way they are doing it is by leveraging some of the products from AWS. They're looking at Amazon SageMaker, which is a fully managed service to build, train, and deploy machine learning models and match patients to therapists. You're making sure that the right people are getting the right treatment that they need at the right time. They're also using another thing called SageMaker Ground Truth, which allows them to create data labeling services to make sure that those data sets for the machine learning are learning the right way, and that they're continuing to grow. They move very fastly, and they're able to match people up for their condition and with the therapist that they need. And they've added Amazon Transcribe for speech and text capabilities. So people aren't necessarily limited to just a keyboard or physical documentation the way they used to do it. So we see Talkspace leveraging many of the Amazon Web Services to grow beyond where they're actually at. By using these services, Talkspace was able to scale services for over 2 million patients. Their platform user attrition was reduced from 20 to 10%. They get an increase in therapist notes, which are fantastic, of 20%, because oftentimes therapists may miss something because they're trying to record everything. And because they're using technologies that allow for that information to be recorded and then transcribed, they're not missing those things anymore. We saw a 77% therapist satisfaction rate with the use of Talkspace, and thousands of therapists are ranked to match individual client needs now using the machine learning and AI technologies inside of Amazon Web Services. So there's one of the people that are using Amazon Web Services to attack some of these health inequalities that were brought out during the pandemic. Another area we talked about, the nursing homes. Okay, globally, 1 in 6 people will be 60 years or older by 2030. Okay, that's not that long away. We're only talking about 7 years away. So 1 in 6 people are going to be 60 or older. That is going to result in a shortage of about 18 million healthcare workers. So who's going to take care of these people? Who, in situations where they need the additional support for healthcare workers, where are we going to find 18 million people? Well, we're probably not going to find 18 million people, but are there technologies that we can leverage to help reduce the manual overhead associated with treatment? Well, enter a company called Kepler. Now, Kepler has created a thing called a night nurse, and it uses an artificial intelligence to alert staff when a resident falls or needs attention. And it monitors clients in private rooms and in hallways and common areas using a single optical sensor. When we first started looking, probably 5 years ago at falls and falls detection, we would often have to set up multiple cameras in multiple angles and try to figure out what's the difference between a person and what's the difference between an inanimate object. Well, Kepler's come a long way, and by using AI, they're able to detect things like, a person rolled over in the bed, or maybe a pillow fell off the bed, or maybe someone had a cat on their lap and the cat jumped off, and it wasn't the person falling. In the early days of falls detection, there were a lot of false alarms, and it created a lot of alarm fatigue around the clinicians that were treating the patients and the nurses that were watching them and the staff that were watching people. And Kepler has come along, and they've done a lot of intelligence into their system to be able to ensure that people that actually are moving around are actually people and not objects around them that are just being moved inadvertently in those particular things. And they're able to do it with a very limited amount of optical sensors, reducing a lot of the overhead, reducing the hardware that's associated with it. So this is really, really a good thing to take a lot of burden off of staff. How are they doing it? Once again, they're using AWS services. In particular, they're using ECS, the Elastic Container Service, to manage those edge devices, those those sensors at those facilities, and they're able to scale very quickly to meet those demands. Also, the EC2 allows for them to reduce the time required for the neural network training. It used to take weeks and weeks to train a particular place. Now they get that down into just a few hours with just a few tests. So dramatically reducing the impact and how quick they can meet the need of installing their systems. And so what are the benefits? What happens of it? Well, of course, resident safety and well-being. And it scales to meet an immediate demand. In most facilities, falls detection is an immediate demand that needs to be addressed. It monitors, it manages, it will restart the edge devices automatically. There's not necessarily manual intervention that needs to happen, and it substantially reduces the time for neural network algorithm training. Genomics, we talked about genomics, okay? A rare disease, okay? A rare disease is a disease that affects fewer than 200,000 people in the United States, okay? There is an extensive number of separate rare diseases, a lot of different variants that only affect a very small subset of people. But what we found out is that 1 in 10 people have some type of rare disease, whether it affects their day-to-day activity or not, they have this particular disease. Well, the National Institutes of Health Common Fund is funding a research study that allows clinical and research centers across the United States to work together to improve diagnosis and care of patients with these undiagnosed disease. And they're using the cloud to collect that particular information and do that. What they do is they have 2 main goals. They want to provide answers for patients and families affected by the conditions, and they also want to learn more about rare and common diseases. The way they do that is they utilize some tools that allow them to do a data processing technique called joint variant calling, which allows genetic sequencing data to be compared against hundreds and hundreds of other samples, looking for similarities, because it's very rare that you'll find a 100% match, but they're looking for similarities. And whenever a new diagnosis is made, researchers can determine whether or not other patients suffer from either the same disease or something like it. And then they can see if are certain treatments better, are certain things actually able to better provide outcomes to patients who present these particular disorders. They utilize the Amazon cloud. They utilize the basic tools to analyze the bioinformatics and genomic data. But utilizing Amazon's web services, they can take more than 800 samples at a single time, okay? And they expect that number to be more than 5,000 to 10,000 samples at exactly the same time, be able to do that many within a few years. So they're able to take genomic sequencing and push it through massive amounts of data very, very quickly in order to see who these particular patients match up and if there's particular treatments that are available. This is a big deal, and it is being shared across physicians. It's being shared across research facilities to help us to greatly reduce some of the burdens that are put on through these particular diseases and conditions. Now, we talked about things that happen through COVID, but what about the next COVID? Okay, Cornelius Romer, who's at the University of Basel, says we can say with certainty that something is coming. Okay, probably multiple things are coming. Whether they also lead to many hospitalization and death is a big question. Basically, what he's saying, he's a computational biologist, he's basically saying something else is coming and we should be prepared for it. Okay, don't take it lightly. Just because now it seems that the COVID-19 is kind of coming under control doesn't mean that something else isn't coming. He's saying something else is coming. And what are we doing to address that? Well, I want to bring you back to a company that many of you have probably heard of, Moderna, and talk about some of the things that they're doing and some of the things that they've been doing. Now, we know Moderna as a vaccine company. They were one of the leading vaccines in the United States for the COVID-19 virus, and very instrumental. And what they did was they utilized a thing called messenger RNA. You may see it often as mRNA. And mRNA is this naturally occurring information in molecules that constantly travel back and forth from DNA, receiving and giving genetic code. Well, Moderna, what they did was they send a messenger RNA with instructions to cells to produce specific proteins that cure or prevent diseases. So with the COVID-19, what they did was they produced a protein that looked like the COVID-19 virus, sent it out, and then the immune system attacks that virus and builds up and can create a response to it. That's the way mRNA is. I know some people often don't understand. It's actually, in general concepts, relatively simple. Now, when you get into it, it's way more complex than that. But the idea is that you can create a naturally occurring protein that looks like the COVID virus, and your body goes, oh, here's the COVID virus, and it fights it and builds up an immunity to it. Well, Moderna, the way that they were able to do this is they partnered with AWS and did their research and their clinical trials on AWS. They did a lot of their analytics and their vaccine development on Amazon's Redshift. They enabled a distribution at a global scale at an accelerated process by utilizing AWS's scaling abilities. Heavily use the machine learning that's available, and even to the fact that their first clinical batch was released only 25 days after completing the sequence. Okay, phase 1 trial was ready 42 days after initial sequencing of the virus. Okay, that's unheard of. Okay, this pace of research was basically non-existent prior to this type of thing. Yeah, we were doing some of this, we were able to push things through, but the pandemic created a situation where the use of these particular tools and these particular services allowed Moderna to create vaccine and go through the initial sequencing and the initial deployments and the initial development of it, and then through the development process at a speed which was unheard of. They have found by utilizing AWS that the preclinical drug development speed and volume is greatly increased. They have saved millions of dollars by avoiding an on-premise data center. They met regulatory requirements very quickly and inexpensively because AWS handles a portion of that, so they didn't have to worry about that. And here's a real kicker. Okay, we know many of the people that are listening to this know who Moderna is. They're very familiar with the vaccine net. They manage their AWS infrastructure with only one staff member. Okay, only one staff member. What they did would have required large groups and large data centers in the past. This is all now being handled in the cloud, utilizing the single staff member to maintain the AWS web service and utilizing the services that are available and continuing to grow every day at AWS. So what about beyond COVID? Okay, we talked about the things that we saw in COVID. We talked about how we're beginning to address the things from COVID from different companies. We saw that even addressing COVID itself. But what about health inequalities even beyond that? What's going on there? Well, in 2021, AWS committed $40 million to advance health equity globally. And so their thought was to create a series of accelerator-like programs that allow for organizations to increase and develop responses much quicker. And so the actions that they were looking to do in 2021 to begin with in this first round was increase access to health services, and then reduce disparities by addressing social detriments of health, and then leveraging data to promote equality and inclusive systems of care. And since then, AWS has allowed organizations, they've selected particular organizations to join their accelerator programs. And through their accelerator programs, they're able to work with, in particular, a company called Publix in the UK, and KidsX, which is a digital health accelerator that's based out of Children's Hospital in Los Angeles, to help organizations grow and become more efficient and be able to get their product, these healthcare focused startups, to create valid solutions along with the existing revenue and customers and US-based operations to get them to the market very quickly and efficiently. And we can see that in 2021, there were 10, and we'll just show you, these were the ones that were accepted into the Healthcare Accelerator cohort. In 2022, of course, AWS expanded that to the UK. And in 2022, we've just recently seen the teams that went through the accelerator cohort and have been released or coming out of their graduation out of that. And AWS continues to support those organizations as they grow. So today, in a very short period of time, we talked about some of the things that are going on in the world around health equality. Okay, and what we've learned today is there's still a lot of work to do. Okay, the pandemic brought to the forefront that there is a magnitude of health disparities. Okay, but we also see that there are organizations that are now focusing on creating new and innovative advances that specifically target health equality. Okay. Specifically, they're looking for answers and solutions to questions that have, quite frankly, existed for quite some time. And we're also seeing that AWS is continuing to prove to be a leader in providing the resources for organizations to make an impact right now, okay? All while helping others prepare for futures and the future growth. Now, today I want to leave you with a saying that Will Rogers said: "The health of nations is more important than the wealth of nations." And I think we can kind of take that to heart. Is oftentimes in our day-to-day business, we're very focused on making money. And I encourage you and encourage everybody that's listening to this to take a moment and start thinking about health over wealth. And that's what Will Rogers was trying to say, was that we need to focus on getting nations healthy instead of as worrying so much about nations getting wealthy. And with that, today, I will leave you with those thoughts.